Good evening, everyone. This is Professor Hanif. I'm a professor of diabetes endocrinology at University Hospital Birmingham in the UK. And thank you very much for joining this webinar where we'll be talking about the micro and macrovascular complications in diabetes. I would like to thank the European Academy of CME for inviting me to give this webinar. As you all know, for the next 30, 35, 40 minutes, I will probably be trying to take you through the latest developments in the management of diabetes, with the focus on the micro and macrovascular complications. Now, in the field of diabetes, the last 5 years have been extremely fascinating and interesting for a variety of reasons. And perhaps the main reason has been the amount of evidence that has been accumulated in this half a decade. And this is going to have a huge impact on the way we manage our patients with diabetes. So what I'm going to be doing in my talk is to go through a bit of the perspective on what the complications of diabetes are, and then we'll try and review the new evidence about it, and finally come through how this evidence can actually be put in practice for the better outcome of our patients. Now, one of the most important things which I always say is the impact that diabetes has on our patients' lives really depends upon the age at which they develop diabetes. Now, the cutoff I use in this data is 60 years. So if you have no diabetes at the age of 60 years, then, and if you develop diabetes after that, it really has a very little impact in terms of reducing your lifespan. So you probably have nearly the normal lifespan if you have no diabetes at the age of 60 years. But if you were to develop diabetes or have diabetes on your 60th birthday, then you lose about 6 years of your life. And if you're unfortunate enough to have diabetes along with a cardiovascular disease, be it MI or a stroke, then you lose about 12 years of life. And that is a huge amount of lifespan to lose. Now, if we actually keep things in focus on what we call the non-communicable diseases and its impact on death, and this is the data from the United Kingdom, and this is really a reflective of what is happening across the world. What is obvious is the biggest portion of the deaths are from heart and circulatory disease, followed by cancer, followed by respiratory disease. And this just gives you a perspective as to still how much death in our patients is caused by heart and circulatory disease. Now, the excess mortality we see in type 2 diabetes is largely related to cardiovascular disease. About 1/3 of the patients with type 2 diabetes also have cardiovascular disease. Cardiovascular disease tends to occur about 10 to 15 years earlier in patients with diabetes. Nearly half of all deaths in people with type 2 diabetes are because of cardiovascular disease, and diabetes accelerates the development of cardiovascular disease in our patients. Diabetes also has an impact on both what we call the micro and macrovascular complications. So if you look at the microvascular complications, nearly 44% of our patients with diabetes develop some kind of kidney disease. 60% of non-traumatic lower amputations are attributable to diabetes. 29% of the diabetes have developed diabetic retinopathy, and nearly half of our patients are obese, along with the contributions that it does to macrovascular disease in terms of heart failure, MI, and stroke. Now let us try to understand how we are doing with the diabetes or the outcome of our patients with diabetes in the last 20 years. And this is a very interesting data that was published in New England Journal of Medicine in 2014. And what it really looks at the secular trends of the development of diabetes in over the last 20 years in the United States. So from 1990 to 2010 to see how we are doing in people both with and without diabetes. And what it actually shows is that when it comes to circulatory disease, be it myocardial infarctions and stroke, the prevalence is coming down. Death from heart is that if you look in people with diabetes more, so the myocardial infarction rates in diabetes down by nearly 7%. But what is interesting to understand in these two graphs is the prevalence rates. Because in people with diabetes, the prevalence rates is nearly 100 times more or nearly 10 times more than people without, without diabetes. As I stated earlier, two-thirds of the deaths in patients with diabetes are due to cardiovascular disease. But let us also try and understand what is happening when it comes to three important markers of cardiovascular disease. One is all-cause mortality, one is death from cardiovascular disease, and one is death from coronary heart disease. And this is the data from the Swedish National Diabetes Register. And what it actually shows is that in people without diabetes, the rates of all-cause mortality are coming down. So is in people with diabetes, and so it's true for death from CVD and death from CHD. But what is interesting to note is that if we actually look from the all-cause mortality in people with diabetes in 2014 is same as in people without diabetes in around in 20 um, in about 2004, which basically means that the people with diabetes are are actually running behind when it comes to care about 20 years in people without diabetes. So this is, let me get the marker. So if you look in people with diabetes in 2014, their all-cause mortality is nearly same about 20 years down the line in people without diabetes. Now, whenever we call about cardiovascular disease, we think about coronary heart disease, and we should, because the rates of coronary heart disease in people with diabetes are nearly twice when compared to people without diabetes. We also need to remember cerebrovascular disease, things like ischemic strokes, which are again about nearly double in people with diabetes when compared to without diabetes. Now, when it comes to talking about diabetes and cardiovascular disease, one of the things, what I call the elephant in the room, is hypoglycemia. And we should always be aware of hypoglycemia and what impact it has on our patients. Now, this again is the data from United States published in JAMA. And what it really looks at, the rates of admissions in US hospitals with patients on Medicaid benefits with hyperglycemia. And what we find is that the rates of admissions with hyperglycemia in pink are actually coming down substantially. But when it looks at the rates of hypoglycemia, uh, the rates are pretty much the same. There's a slight decline, but the rates are pretty much the same. Let us see why this is important. And this is the data from the DEVOTE study. What it actually shows is in patients who've got severe hypoglycemia, your risk of subsequent mortality increases by nearly fivefold. And if you've got a severe hypoglycemia prior to all-cause mortality, then your rates of dying are nearly increased by sevenfold. indicating that the hypoglycemia is an important marker in our patients when it comes to cardiovascular events as well as all-cause mortality. Now let's try and understand what we can do to manage our patients. And this is again the Swedish National Diabetes Registry data. And what it actually shows us is what happens to our patients in terms of the risk of dying or excess myocardial infarctions or risk of getting acute myocardial infarction. So we have got 5 risk factors here. So one is diabetes, one is blood pressure, cholesterol, smoking, lack of physical activity. Now, if somebody has got all these 5 risk factors, and if they are aged more than around 55 years, the risk of having an acute myocardial infarction is increased by nearly 7-fold. But if these risk factors are managed, all of them, your risk of actually developing a cardiovascular disease or acute myocardial infarction is actually less than in somebody without diabetes. So what it is actually showing is that if we are able to manage the risk factors better, which means control the diabetes or HbA1c in the target range, control the blood pressure, control the cholesterol, increase physical activity, encourage your patients to stop smoking, then they can almost reverse the risk of, of increased myocardial infarction due to diabetes. This has also been shown in the Steno study, in which there were 2 arms. One was the conventional arm and one was the intensive therapy arm. In the intensive therapy arm, the HbA1c, the target HbA1c was around 6.5. The total cholesterol was less than 175. Trigs were less than 150 and blood pressure 130/80. And in the patients who achieved this, they were able to reduce the all-cause death rate by nearly 46%, which means at a 21-year follow-up, the lifespan of the patient was nearly increased by 7.9 years. And if you go back to my first slide, I said that if you have got diabetes at the age of 60, you lose about 6 years in life. But if you are able to manage all these risk factors, if anything, the data is suggesting that you could uh, possibly gain 2 years of life as extra. Now, whenever we talk about diabetes and the burden of cardiovascular disease, we also need to understand the cost, because we all know that the medical treatment across the globe is becoming more expensive, and this causes a huge burden on the health service. I'm going to use some of the data from the UK where I work in the NHS to see what the cost of diabetes is. The current prevalence rates of diabetes in the UK is around 5%. About 3.5 million people in the UK have got diabetes. The total spend of the NHS budget in the UK is around 110 billion. So about 10% of the NHS budget, which is about 11.4 billion, is spent on managing diabetes. But what is interesting to know in that is out of that total 11.4 billion, nearly 80% of it, about 9 million, actually goes in managing the complications of diabetes. While the actual drug cost of managing diabetes is around 2.4 billion. Again, indicating that if somebody develops a diabetes complications, the cost actually multiplies by many a factor. Now let us try and see what are the current tools in our armamentarium for managing diabetes. And here I'm going to be focusing on macrovascular complications. So this is your cardiovascular disease and cerebrovascular disease, and trying to look at the evidence. So the current evidence that we have got actually suggests that if we want to decrease the cardiovascular risk in our patients, the, 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 the treatments that have got the strong evidence to show that we can decrease the risk is managing the blood pressure or antihypertensive therapy, control of LDL cholesterol, that is mainly through statin therapy, use of antiplatelet therapy after the patient has had an infarct or secondary prevention. So these have got good evidence. But when it comes to things like controlling diabetes or using drugs to control the diabetes, the evidence is uncertain or not fully established. And the same is true for weight loss and lifestyle intervention. Why this is important for us to know. Our current emphasis on all the medications that we had for diabetes so far have pretty much focused on what we call the glycemic control for managing diabetes. And what we hope is by doing glycemic control, we will decrease the cardiovascular risk. Now let us examine the evidence that has been there for glycemic control. In the last decade or so, there have been a huge number of clinical trials done in diabetes involving nearly 100,000 patients. And this has really improved our understanding about diabetes and its outcome. So if you look at the major clinical trials that have been done in diabetes, starting from DCCT, UKPDS, Advanced Accord, and VADT, what all these trials with big follow-up, big well-designed clinical trials, randomized control, and what these clinical trials actually showed was that by controlling the HbA1c, we can reduce the microvascular complications, and this was pretty much across the board. But when it came to the macrovascular complication, the evidence was not very strong, especially in the short term. Only a trial like the UKPDS showed that after more than 10 years of managing diabetes, you can actually start seeing the benefit. So this benefit is only coming from sugar control or glycemic control with the anti-diabetes medications. Look at comprising nearly 100 C. There is evidence in the meta-analysis in this forest plot of showing a positive outcome, both in terms of MACE, all-cause mortality, cardiovascular deaths, showing that there is a beneficial effect. But for the patients to have this beneficial effect, they have to wait for a very long time. This is what we call the legacy effect of diabetes. So what does that mean? So what it means is that if you have a patient and if you manage them very well in the first 10 years, keeping their HbA1c around the 7% mark, then about 10 years down the line or 20 years down the line, you see the beneficial effect in terms of cardiovascular disease by 15% reductions in MI and 13% reductions in all-cause mortality. So the story so far has been that if it comes to diabetes and diabetes management, what is obvious is that if we are going to control for diabetes, just the sugar levels with the current available medications at that time, we will get a positive effect. But for us to get a positive effect, we had to wait for nearly 15 to 20 years. So pretty much the whole story of diabetes and glycemic control with the drugs available was that the effect on cardiovascular outcome was long term. Now things started changing. The reason things started changing was that the FDA mandated that all new diabetes drugs should have a cardiovascular outcome study. And this really helped us to improve the understanding. So the first few drugs that were trialed in terms of cardiovascular outcome in well-designed clinical trials were the gliptins. So we had the Savior-Timi with saxagliptin, Examine with elagliptin, and TCOS with sitagliptin. And what all these clinical trials shows was that these drugs were not were not that these drugs were not harmful, but but they did not show any cardiovascular benefit. So there was no cardiovascular benefit, but these drugs were not harmful. And if you look at hazard ratio of all these clinical trials were 1. So what it proved was the Gliptins is a class of drugs was good because they did not cause any harm, but there was no benefit in terms of the cardiovascular, in terms of the cardiovascular effects. Now the things started changing around 2015 when one of the first trials with the diabetes drug, and I'm very careful in choosing my words here, which actually showed a cardiovascular benefit with the diabetes drug, and this was with empagliflozin, an SGLT2 inhibitor. Now, before that, there was a small subset of patients, about 340 in UKPDS, which had shown benefit with metformin, but it was not a large trial and it was not a primary outcome trial of metformin. So what did this show? So what it actually showed in EMPA-REG was with an SGLT2 inhibitor, empagliflozin, when it came to the 3-point MACE, which is the standard test used in all cardiovascular trials, there was a reductions in the cardiovascular death by nearly 38%, and this was the big driver of this trial. The non-fatal MI was also decreased, although not statistically significant. The non-fatal stroke, if anything, there was a slight numerical increase, and the hospitalization for heart failure was decreased. So this was one of the first clinical trials that showed that a diabetes drug could actually reduce the cardiovascular outcomes, and this was considered to be huge. Following this, there was another trial with another SGLT2 inhibitor. This was the CANVAS study. Again, CANVAS study showed that the 3-point MACE, which included cardiovascular death, non-fatal MI, non-fatal stroke, along with the fourth one, hospitalization for heart failure, they were all showed a positive effect in people with diabetes. The results of CANVAS were a bit more standardized, as no single component was shown to have more benefit than the others. But the thing about the empagliflozin study as well as the CANVAS study was these were secondary prevention trials, which meant that most patients, both in CANVAS as well as in empagliflozin, mostly in empagliflozin, already had a cardiovascular event. So the question was whether this benefit was also seen in the patients who did not have cardiovascular disease previously. For this, we had the DECLARE study, which was done with dapagliflozin. The interesting thing about this study was that nearly 60% of the patients did not have previous cardiovascular disease, which means this was essentially what we would call a primary prevention trial. And what did DECLARE study show us? DECLARE study showed that when it comes to, so DECLARE had two primary endpoints. One was what we call the composite endpoint. One was hospitalization for heart failure or CV death. And in the study, it reached its statistical significance, showing that it was effective in both composition of hospitalization for heart failure and CV death. But most of it was actually driven by hospitalization due to heart failure. But when it came to the primary endpoint, which is the 3-point MACE, DECLARE did not reach the statistical significance, although numerically the events were higher in the placebo group. So if you look at the meta-analysis, which was published in the Lancet in 2018 of all these 3 major cardiovascular outcome trials with SGLT2 inhibitors, what was obvious was that in patients who already had an atherosclerotic cardiovascular disease, what we call the secondary prevention, there was a positive effect seen in all the clinical trials in this forest plot. But when it comes to the primary prevention, which is in patients who did not have previous cardiovascular disease, the effect was not really seen, or it was not there. But when it comes to cardiovascular death and hospitalization for heart failure, this effect was seen in both in patients who had previous cardiovascular disease and patients who did not have previous cardiovascular disease and just had the risk factors. So the effect of SGLT2 inhibitors was positive when it came to heart failure and cardiovascular death in this group of patients. But one of the things that came out from the SGLT2 clinical trials, and especially with regards to canagliflozin in CANVAS, was the increased risk of amputations. What this clinical trial showed was it was increased twofold, and this was both minor and major amputations. And this raised the concerns about the safety of these agents, especially canagliflozin, in terms of the risk of amputations. Uh, these effects were only seen in the single trial with CANVAS, and we are waiting other trials, which I'll talk about, to give us more answers regarding this. But when it comes to declare with dapagliflozin as well as empagliflozin, when it came to the side effect profile was pretty much similar to placebo, be it around malignancy, bladder cancer, um, fractures, amputations. There was no difference seen. Uh, Again, there was a slight increase in decay, but otherwise the rates were pretty much similar to placebo, which is a bit reassuring. So it was not only the SGLT2 inhibitors that had a positive cardiovascular outcome trials, they were also seen with the GLP-1 analogs. So what we found with the GLP-1 analogs is that in the LEADERS study, which was with liraglutide, again the 3-point MACE, which included cardiovascular death, non-fatal MI, non-fatal strokes, they were positive, and this was statistically significant. Again in SUSTAIN 6, which is with the semaglutide, which is a once weekly GLP-1 analog, which is now available in the UK, again, there was a positive effect in the 3-point MACE, mainly driven by mainly driven non-fatal MI, non-fatal stroke, along with cardiovascular death. But in these trials, there was no positive effect with hospitalization for heart failure. Again, Harmony, which was with albaglutide, which is again a GLP-1 analog, we saw similar results. So just in summary of the cardiovascular outcome trials with SGLT2 inhibitors, what became very obvious was the 3-point MACE was achieved by EMPA-REG and CANVAS, not so by DECLARE, but the endpoint was achieved in DECLARE, and these were the individual components. And similarly with the GLP-1 analogs, positive cardiovascular outcome trials were obtained by LEADER, by liraglutide, semaglutide, and albiglutide. Now, one of the questions that is asked by a lot of experts across the globe is, are we seeing these effects only in patients who already have the answers in the DECLARE study? So what we tried to do in this study, which we published in JCM, was to look in patients and look at mortality in patients who did not have cardiovascular disease. So this was based on the THIN database, which was a real-world study. We looked at the data of nearly 4,000 patients followed between 2013 to 2015 who were treated with dapagliflozin. And what we found was in the low-risk population, which is the patients who did not have previous cardiovascular disease, there was a reduction in all-cause death by nearly 56%, showing perhaps that even in primary prevention, you're seeing these effects. So while we're getting these cardiovascular outcome trials, we also had trials with what we call the old class of drugs like pioglitazone, to see whether they have got a cardiovascular outcome trials. So this was a trial that was done with pioglitazone and was compared with sulfonylureas that had nearly 3,000 participants in the clinical trial, followed for nearly 8 years, and this trial showed that there was no beneficial effect when it comes to the cardiovascular outcome in these group of patients. Now, as I said to you, this was probably quite a data-heavy talk where we talked about a lot of clinical trials and a lot of evidence that has come about. And if you thought that was enough, the huge number of clinical trials that and will which will improve our understanding of management of diabetes. Now, while the cardiovascular outcome trials are going on, there are also clinical trials which are looking at specific effects. So this is the effect of the drugs, diabetes drugs, in terms of improving the renal outcomes in people with diabetes. So this was the Credence study with canagliflozin, which specifically was looking at the renal and cardiovascular outcomes. Now this study has completed. We are part of this study. The initial results are positive. Uh, the headline results are positive, and this result will probably be reported in April of this year. Now, one of the other questions that is actually raised is, are these clinical trials really representative of all the populations? Because as we know that most of these clinical trials had what we call the white European patients, while we also know that the most people with diabetes are actually in the emerging economies or in countries like the Indian subcontinent and in China. So this was a study, or this was a paper we did as a part of the South Asian Health Foundation UK, in which you look at the nearly 12 studies, and what we found was that the number of patients of South Asian heritage in some of these clinical outcome trials were very less. So the question remains whether these studies are really reflective of the populations. But what was interesting was we had a subgroup analysis of Asian patients in terms of the cardiovascular outcomes in EMPA-REG. And what it actually showed was that the beneficial effect of these drugs in South Asian or in Asian patients was much higher when it came to all the individual components when you compare it to the white Europeans. Perhaps you just think that these drugs might be most useful. So now coming to the last section of my talk, the question is, how is all this evidence will be formulated, or how will it change our clinical practice? Now previously, and this is a part of the multi-morbidity clinical assessment that was done by NICE. I was involved in NICE for more than 8 years. And what this actually does is that it actually moves the goalpost when it comes to managing diabetes. Previously, the goalpost for managing diabetes was glycemic control, or what we call the sugar control, or HbA1c was the most important marker, both for microvascular and macrovascular disease. What the current evidence is actually showing is that HbA1c is still an important marker for reducing microvascular complications. But when it comes to macrovascular complications, which affects most of our patients with diabetes, we have to think beyond the HbA1c, or what we call the multi-pronged approach, or what we call the cardiometabolic management of diabetes. Following the following the publication of this trial, the ADA-ESD consensus report 2018 was actually released and simultaneously published in Berlin. And this slightly changed. We are going to manage that in the coming year. Back to the previous version of ADA-ESD consensus report, and this is from 2015. What it actually did was that the first line of agent for managing diabetes was lifestyle, followed by metformin. And after that, you could almost use any of the agents that were available for managing diabetes. And the way we were asked to choose these agents were based on a single factor, which is called individualization of treatment. And how we individualized the treatment was left to the choice of the individual physician. How does the 2018 version differ? Now, the 2018 version takes the updated evidence which has been generated in the last 2 years when all these trials were affected. There is a greater focus on lifestyle intervention and weight loss and obesity. There is a greater focus on patient-related issues and self-management, and the new evidence which has come from the cardiovascular clinical trials has been taken into consideration. So this is what's been developed, what is called the decision cycle for patient-centered glycemic management in type 2 diabetes. What it actually looks at is it looks at assessing the patient characteristics. So it gives clear indications as to how these assessments should be done so that we can individualize the treatment. So it is looking at the current lifestyle. It is looking at comorbidities for the first time, things like atherosclerotic cardiovascular disease, CKD, and heart failure. Then it looks at clinical characteristics like age, HbA1c, weight, motivation, and socioeconomic criteria. Once you've done that, it is a question of shared decision making, agreed management plan, and implementing the management plan. So what are the changes? This is quite a busy slide. I'll just split it and take into various components to try and explain it. So the first component that has been changed is the therapy now at the same time they started on metformin. After that, it is to look at whether the patient has got established atherosclerotic cardiovascular disease or chronic kidney disease or heart failure or not. And in patients who have got atherosclerotic cardiovascular disease, CKD or heart failure, the first drug of choice is, if they've got atherosclerotic cardiovascular disease, is GLP-1 receptor agonist, either or an SGLT2 inhibitors if they are not able to tolerate. And if they have got heart failure or CKD, then SGLT2 inhibitors to be used as first line, and if they're not able to tolerate, to go to GLP-1s. Similarly, in patients who don't have ACVD or CKD, but the compelling need of management is to minimize hypoglycemia, then the agents of choice are either DPP-4 inhibitors, GLP-1 receptor agonists, SGLT2 inhibitors, or TZDs. In patients without ACVD or CKD, where the compelling need is to minimize weight gain or promote weight loss, the agents of choice are GLP-1 receptor agonists or SGLT2 inhibitors. And finally, and importantly so, in patients without established ACVD or CKD, where cost is a major issue, which is in the majority of countries, then the agents of choice are sulfonylureas or TZDs. So what the ADAC consensus statement is actually doing is, it is telling us that how we can manage our patients better. It is also trying to bring in the new and the latest evidence that is available, and is also giving us an idea about how this evidence can actually be used to the beneficial effect of our patients, and how to individualize these treatments for our patients. So how is the diabetes manager looking at it? The way I look at it is what I call the diabetes, cardio-renal, and heart failure continuums. So the first wheel of this, the first tar of this wheel is what we call primary prevention, following which you have got the atherothrombotic continuum. So these are the risk factors of dyslipidemia, hypertension, inflammation, and smoking, leading to MI and stroke, and their management. And this is followed by what we call the renal continuum. So this is normal renal function, albuminuria, EGFR, decreasing EGFR, the ESRD, and then we have got the heart failure continuum. So now the diabetes management is shifting from a pure glycemic focus to these various diabetes, cardiorenal, and heart failure continuums. A final few slides. Now, one of the most important factors, which I think is to be considered whenever you're talking about any landmark clinical trials, is the numbers that are needed to treat to prevent one death. So if you remember in the statin era in 1994, in high cardiovascular, you had to treat 30 patients to prevent one cardiovascular death. With the ramiprole, in which 29% were on a statin, you had to treat 56 patients for 5 years to prevent one cardiovascular death. But with empagliflozin, when nearly 80% of the patients are already on ACE inhibitors, which offer the cardiovascular benefit in terms of death, statins, which are again decreasing death, we just have to treat 39 patients just for a period of 3 years to prevent one cardiovascular death. And the numbers needed to treat cannot ever get better than this. Now, one of the questions that I'm always asked is, how do these drugs work? It's very difficult to find out. There are a number of hypotheses. I'm just going to briefly mention them. So these are either they reduce the glycosuria by reducing HbA1c, reducing total body fat, or increasing uricosuric, what I call the Steiner effect. Or it could be by natriuresis, by reducing the plasma value, reducing the blood pressure, reducing TGV, or through the sodium hydrogen exchange. As I mentioned to you, currently all these are hypotheses. There's also the hypothesis that this could be through a tubular glomerular feedback inhibition, which these agents have on the bombs on the glomerulus. There are a number of studies that are going to find out the possibility. What is very obvious is that these drugs do work and do reduce the cardiovascular death. So in my final slide, what I'm going to say is that cardiovascular disease remains a burden in people with type 2 diabetes. Data in type 2 diabetes suggests that lower glucose improves cardiovascular outcome, but you have to wait for a normal period of time. Traditional glucose lowering therapy shows cardiovascular safety, but not a consistent impact on cardiovascular outcomes. New glucose lowering therapy showed differential outcomes within and between the classes, but there's a little data on saltations. And cardiovascular management of people with type 2 diabetes is complex and needs individualizations of current options available. Thank you very much. I'm happy to take any questions. So the first question I have here is from, I'll tell the questioner's name and answer the question. This is from Dr. Jitesh Agarwal. And he asks, is it necessary to lower down HbA1c if blood sugars is normal? I think that's a fantastic question. So let me just put this out. So if I have got a patient who is currently on metformin, has got an HbA1c of 7% and had a cardiovascular event. And the question is whether I will be using an SGLT2 inhibitors or GLP-1 analog. The current evidence, along with what has been suggested by ESD, ADA consensus, is yes, we should perhaps be considering either an SGLT2 inhibitors or a GLP-1 analog, because there is evidence to show that these agents actually have vascular outcomes in these group of patients. So that was a very good question. So the next question I have from Dr. Yalamudi. So he's asking about the increased fracture risk after initiation of canagliflozin. I think again this is a very good question, and again there is the evidence that has come from the Canvas study, which shows that canagliflozin is associated with increased risk of fractures and amputations. There have been other studies done. These have been mostly real-world evidence, large database studies, which have shown that this risk is less, while there have been some other studies which have talked about increased risk with canagliflozin. We perhaps have to wait for the Credence trial, which is going to report in April of this year, before we can certainly answer these questions. But currently, the advice is that if somebody has already got peripheral vascular disease or increased risk of osteoporosis, it is better to avoid canalicular flows. The next question I have is from Sunil Jain, and he talks about drugs helpful in diabetes with heart failure with preserved ejection fraction. Again, I think this is a fantastic question. As we know, let me try and explain the difference between the two. So there is something what my cardiology colleagues call is one is HFrEF and HFpEF. So HFrEF is what we traditionally call as heart failure with reduced ejection fractions. So in this patients, there is a systolic dysfunction of the heart. So if you actually look at the heart, these patients have got reduced ejection fractions, and if you do an echo, their ejection fraction will be reduced and they will have heart failure. So this has been classically described as HFrEF. The other kind of heart failure which we see in people with diabetes is what we call HFpEF. So this is heart failure with preserved ejection fraction. Now, to diagnose HFpEF is slightly difficult. So to diagnose HFpEF, the first thing you need is the patient should be symptomatic, which means the patient should have shortness of breath. Along with it, if you measure the BNP in these patients, the BNP should be elevated. And if you do an echocardiogram of these patients, these patients are diagnosed as having HFpEF. Now, what the current data suggests with the SGLT2 inhibitors is that both in HFrEF as well as in HFpEF patients, that these drugs are beneficial in reducing heart failure. Now, this has been shown only in people with diabetes, in both with cardiovascular events and without cardiovascular events. Now, a number of clinical trials have actually started with SGLT2 inhibitors in people without diabetes, and we are waiting for these to be reported in the next few years. Again, I've got one question from Dr. Yalamoudi, and he asks is, what is the effect of glycemic control in progression of diabetic retinopathy? Again, I think the effect is very obvious. Controlling diabetes is very important, and in trial after trial, it has shown that bringing down your HbA1c by 1% reduces the risk of retinopathy by nearly 24%. But what one needs to be careful is that if the patient has got pre-proliferative retinopathy, if the drop of HbA1c is very steep, if it drops to 1 to 2% very steep, then the retinopathy may get worsened. Now, the next question is from Dr. Kubiran, Indumati Kubiran. And the question is, how do we apply the data from clinical trials into real-world practice, especially in a country like India? I think this is a very fascinating question. I've been to India. I've been involved in a lot of my projects in India. Now, one of the big challenges that we have got currently in India are two. The first big challenge is that we've got a large population with diabetes in India. Now, generally, the understanding was that type 2 diabetes in India was a disease of what we call the middle classes in India, or people who are affluent, and it was a disease of affluence. But what is very interesting is that the new data that is actually coming from places like Hyderabad and others actually shows that even in the what we call the lower socioeconomic state of the Indian societies, in villages, in some of the economically deprived communities, the prevalence of diabetes is very high. Now, this we can use the current evidence to the best of the advantage. Now, what the ADAST and the current evidence actually shows is that in some of the patients, in some of the new drugs which are expensive, can actually be used to reduce the cardiovascular burden in patients, because that actually stops them from having additional costs which they will incur if they were to develop if they were to develop the complications. But at the same time, it is a choice of drug zones and metformin and sulfonylureas, which are not very expensive, which actually can be used in patients whose affordability is less. So it is giving that choice of using appropriate treatments in appropriate patients. And this is not only taking into considerations their medical conditions and the cardiovascular risk, is also taking into considerations their socioeconomic state. So as I said to you, it's not easy, but very possible. Um, Gosh, the data, the data is not very strong in terms of its suggestion of increased increasing UTIs. SGLT2 inhibitors, genital. So this is and most of these things can be treated quite easily by using things like canesten cream and others. And these are found to be higher in patients with um, with poor diabetes control. There's another question from Jitesh Agarwal about which is the safest drug to use in CKD. I think this is a very good question. So if the answer question is the safest drug in CKD, the current evidence is perhaps the GLP-1 analogs, which have actually shown that they could be used up to an eGFR of 15. DPP-4 inhibitors again can be used in patients on hemodialysis, so these two drugs are safe. Obviously, metformin cannot be used. There's increased risk of hypoglycemia with sulfonylurea, so it's better to be avoided. One can use insulins if that's the only option available. But if the question were, are any of these diabetes drugs have a positive effect in CKD patients, the answer is perhaps the SGLT2 inhibitors. The initial data from the Credence study with canagliflozin is actually suggesting that these drugs were maybe protective in reducing the eGFR, and this was shown in EMPA-REG, CANVAS, and DECLARE. So these drugs are protective to the kidneys in terms of reducing the eGFR, and also in terms of reducing uh, 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 um, in reducing proteinuria. The next question is from Dr. Indumati Kavirun, and she says, where our phenotype is different from Caucasians, and I think she's implying whether the South Asian phenotype is different from that of a white European. And I think this is a very interesting question, and a number of my decades of life has done in trying to do research on this. I think that there is perhaps some suggestion, and I said to you, some suggestion, because I think the number of studies that have been done in South Asians to really fully understand diabetes have been less. We set up the United Kingdom Asian Diabetes Study about 2 decades ago in Birmingham, and we got other studies. There is some, and the reason why I say that is that the disease we see in a South Asian population, that seems to be a bit more aggressive in terms of the complications. So diabetes tends to occur at a younger age. There are more complications, both in terms of microvascular complications and macrovascular complications. But what is also interesting is that when it comes to the response of a South Asian patient or an Indian patient for these diabetes seems to be different. So perhaps in an Indian patient, the story is not only of insulin resistance, but it's also of less of beta cell mass. So the less beta cell mass could be a factor that is contributing into the disease process, and therefore we are seeing probably a different response, or perhaps even better response for some of these agents. Uh, so this is from Kenneth Crispin. He asked, SGLT2 inhibitor seems to be effective in CKD. Aren't they are contraindicated in advanced CKD? I wouldn't use the word contraindicated. So let us understand two things here. So when it comes to SGLT2 inhibitors, there are two different mechanism of actions that are, when it comes to glycemic control, so that is only looking at reducing the HbA1c, what we find is that once the EGFR is less than 60, in most cases, and specifically once it's less than 45, these agents don't work in bringing down the HbA1c because they require a functioning kidneys to put out the extra glucose. But EGFR is 45 don't work. So they shouldn't be used because they are ineffective in bringing down the HbA1c. But when it comes to protecting the kidney, so which is reducing the EGFR and perhaps decreasing the proteinuria, the possible mode of action is, as I showed in my slide, is through the tubular-glomerular feedback mechanism, which is slightly different from the glycemic mechanism. And by these mechanisms, they could offer a protection to the kidneys even at the low EGFR. As I mentioned in the Cleveland study, this is being tested because in the Cleveland study, the patients have got an EGFR which is lower than 30, where these drugs should not be used. This again is a good question from Dr. Ajwit Shah. And he asked whether SGLT2 inhibitors can be beneficial in type 1. I think this is a great question. The theoretical answer is yes. They should be beneficial in SGLT2 inhibitors in type 1 diabetes because SGLT2 inhibitors do not require a functioning pancreas to bring down the blood sugar. So they basically are acting through the kidneys. And in patients with type 1 diabetes who've got functioning kidneys, don't have kidney disease, these agents should work. And that's great. So what is the evidence? So the evidence is that have been done, dapagliflozin in people with type 1 diabetes, which have shown these drugs to be effective. So are they licensed to be used? The answer is no. Why are they not licensed? The risk of DKA in people with diabetes, with both type 2 and type 1 diabetes, is increased with SGLT2 inhibitors. And therefore, one needs to be careful when we use in type 1 diabetes patients. Why we need to be careful? So what these drugs actually do is they make you flush out the extra glucose levels. Because they're acting independent of the pancreas, the glucose is being flushed out by the kidneys. With the same amount of insulin, they will start having hypoglycemia. And if once the patient starts having the hypoglycemia, they start cutting down the dose of insulin. And it could be that they cut down the dose of insulin to such an extent that they can develop decay. While at the same time, the SGLT2 inhibitors are also known to have a ketogenic effect because of their actions on glucagon, and therefore there is an increased risk of ketoacidosis. So theoretically, yes, these agents could be useful in type 1 diabetes, but we have to wait for more evidence, and we need to have a better understanding about how much dose of insulin should be reduced, because I wouldn't reduce the dose a lot because the risk of decay is high in these patients. Dr. Shanti Shah, up to what level of EGFR can be used in SGLT2 inhibitors? I think I answered this question. Current license indications is up to 45, but as I said to you, once the credence study comes in, the license may change because then these agents will be used beyond their glycemic control um, uh, ability, because then you will start looking at them as drugs that are protective towards the kidneys. Um, Leni Mehta, Dr. Leni Mehta, she wants to know, when do start antiplatelets in diabetes? So the current evidence actually shows the only reason you will start antiplatelets in patients with diabetes is that if they have had a cardiovascular event. So if they had an MI, if they have a stroke, or if they have got peripheral vascular disease, then only one should consider starting an antiplatelet therapy. In patients who do not have these events, there is no evidence, and there's no evidence to suggest that the antiplatelet therapies are useful. Um, this question from Dr. Damanjit Kaur. In NASH-related cirrhosis, early stage drug of choice for controlling sugars or diabetes? I think it's a fantastic question. So currently we've been enrolled in a lot of clinical trials on patients with NASH. Now, the current evidence is the drugs that have been shown to be safe as well as effective, not only controlling the diabetes but having a positive, so far have been metformin. Pioglitazone has got some evidence to show that it works. There was a study that we were involved in called the LEAN study, which showed that GLP-1 analog, like liraglutide, is useful both in terms of reducing sugars or diabetes, at the same time helping the patients reduce the weight and shift the fat from the liver, which is an important part in NASH cirrhosis. Um, Again, so then the best was, is there any safety study of SGLT2 inhibitors in pregnancy? No, there is no study, and I would strongly advise not to use SGLT2 inhibitors in patients who are pregnant. And if you're giving any of these drugs, be it SGLT2 inhibitors, GLP-1 analogs, DPP-4 inhibitors, statins, ACE inhibitors in women of childbearing age, always advise them that if they're going to get pregnant, that they have to stop these drugs, because these drugs may have a teratogenic effect on the fetus. Yeah, so this is again a very good question from Dr. Prakash Chetwani. When we should start statins in diabetic patients in absence of cardiovascular disease, or is it not indicated in absence of cardiovascular disease? When it comes to statins and diabetes, what I always say is this. If a patient with diabetes, especially with type 2 diabetes, is not on a statin, then there should be a strong reason why they are not on a statin. All patients with type 2 diabetes should be on a statin, which is, and I think there is a very strong evidence to actually support that. Even in people with type 1 diabetes, once they're above 30 years, they should be on a statin. So all patients with diabetes should be on a statin unless there is a strong reason for them not to be, either they're not able to tolerate or have got the side effects. If not, all patients with diabetes should be on a statin, irrespective of disease. Yeah, again, a very interesting question from Damanjit Kaur. In females with diabetes who are trying to get pregnant, what is the drug of choice? Whether they should start insulin? The answer is yes. I think if you've got a patient who has got type 2 diabetes, the most important advice you want to give them is to make sure that the diabetes control is spot on. I would want them to have an HbA1c of 6.5. So I think you have to control the diabetes very tightly, and to do so, you may need to start insulin, because the only two drugs licensed in pregnancy are insulin and metformin. And the reason why it is important to have tight glycemic control at the time of conception is that if at the time of conception there is evidence to show your diabetes controls is not good or is not perfect, then it can have a teratogenic effect on the fetus. So therefore, it's very important to have got good glycemic control at the time of conception. And in most cases, you may need to start insulin. Uh, trying to have loads of questions. I'm trying to use uh, the ones that are not covered. There's one question from Dr. Yalamudi again. He says, how can we control the situation of amputations in diabetic foot? I think this is an important question. I think the important thing about when it comes to amputation, the most important thing is prevention. The way I would organize a diabetes foot care is to make sure that we prevent diabetes ulcerations. And this could be done through regular checkups. So you actually have the patients, you check their feet to make sure they are clean, the peripheral pulses are available, and the vibration sensation neuropathy is intact. Again, there needs to be advice given on footwear, especially in an Indian context where people wear open shoes or what they call chappals. You have to advise them that they have to be very careful, especially in villages where they're walking in areas where they could get hurt. They have to examine their feet regularly, because even a small wound can get worse and lead to ulceration. You also need to make sure they look after their hard skin, make sure they apply some kind of a cream or keep their feet dry, and also look after their nails. So that is the general foot care advice, which is very, very vital in terms of prevention. Once, if a patient develops an ulceration or a wound on the foot, this should be considered an emergency. The first thing what you have to do is to establish whether the vascular supply is fine, which means the peripheral pulses are good, and try to advise the patients to reduce the risk factors, so things like stopping smoking, controlling the diabetes better, controlling the blood pressure, starting them on statin. That is very important. And if there is a decrease in vascular supply of this peripheral vascular disease, then perhaps a vascular surgeon should be involved to improve the vascular supply, because without doing that, the foot ulcer will not heal. Establish whether the foot ulcer is a vascular ulcer or a neuropathic ulcer. If it is a vascular ulcer, then you have to look after the blood supply, but if it's due to neuropathic ulcer, especially in the areas where there is pressure applied, then you also need to start considering how you would try and elevate the wound in terms of trying to shift the pressure points. At the same time, it is also important to get an X-ray to make sure that the ulcer is not involving the bone and there is no evidence of osteomyelitis. Early use and aggressive use of antibiotics is very, very important, because that will prevent the further damage of the foot. At the same time, the diabetes control needs to be good, the cholesterol control needs to be good, and the blood pressure. So it is so the best way I feel a diabetes foot ulcer should be managed is in a multidisciplinary team that should have a diabetes endocrinologist, that should have an easy access to vascular surgeons. They should have been what we call a chiropodist or podiatrist who looks after the foot, or an orthotics who can advise on the shoes, along with the nurse who will do regular dressings, and a nutritionist. So it is important to manage them, because by good management, amputations can be prevented. It's entirely preventable complications of diabetes. So that was my last question. So I would like to really thank all of you for joining me in this webinar, which I really enjoyed. And thank you for asking me lots of questions, which were very, very interesting, and hopefully they were useful, and I really enjoyed it. I've tried to answer as many as I could, and therefore, thank you very much, and I really appreciate you all joining me, and have a good evening. Thank you. Bye.